Hi, I'm Jacqueline Bitsavich, and I'm continuing with my video presentations. Today I'm going to be discussing a case study of a cerebrovascular accident and respiratory acidosis. My objectives are to illustrate the past medical history of a patient having an ischemic cardiovascular accident, or CVA, and develops respiratory acidosis. By the end of the presentation, the learner will be able to discuss the pathophysiology of a CVA and respiratory acidosis and their impact on one another, discuss the medications the patient would be prescribed for a cerebrovascular accident and respiratory acidosis, the concerns with drug-to-drug interaction as well as any age-related issues, review the overarching concepts of nursing practice impacted by a CVA and respiratory acidosis and impacting key problems, identify the psychosocial concerns related to the case study, and identify nursing diagnoses related to CVA and respiratory acidosis. My case study, past medical history of Anna Jenkins. She is a 76-year-old female Caucasian of Irish-Russian descent. She has no known drug allergies. She's 5'6" and weighs 146 pounds. Her educational level is a high school graduate. She is a mother, wife, and grandmother. She is retired. Her occupation was she was employed as a factory worker on an assembly line working the night shift. She only speaks English language. Her income level is middle class. She's married for 52 years. She lives with her husband. Together they have 4 children, 2 sons, 2 daughters, and multiple grandchildren. Her past medical history includes hypertension, hypothyroidism, asthma. She's a former smoker, and she has degenerative joint disease resulting in arthritis of her bilateral knees. She uses glasses to help her to correct her vision, and she is slightly hard of hearing. Anna Jenkins' current medication: she takes multiple medications on a daily basis: Toprol XL 25 milligrams PO daily, Norvasc 50 milligrams PO daily, both for her hypertension, Synthroid 125 micrograms PO daily for her hypothyroidism, Advair 250/50 Discus 1 puff twice a day for her asthma. She takes oxycodone 5 to 10 milligrams 1 to 2 tabs every 4 hours as PRN as for needed for severe arthritic knee pain, and she also takes over-the-counter analgesic Tylenol arthritis for arthritic knee pain and discomfort. Subjective presentation: Anna's story. I woke up and took my morning pills. I was standing at the kitchen counter and I was making my morning cup of coffee when all of a sudden I couldn't pick up the creamer with my left hand to put in my coffee. My left hand, arm felt numb, weak and numb. I realized that I couldn't move my left leg or my foot. My vision was changing and I couldn't see my left side. I couldn't see the cup of coffee. I called for my husband to help me. He helped me sit down on the kitchen chair and immediately knew there was something wrong, and he called 911. I was able to talk just fine with my husband. I was able to move my right side, my hand, my arm, my leg, my foot, but I couldn't move or feel my left side, my arm, my left hand, my arm, my foot. And I just started to feel a little anxious, a little nervous, some shortness of breath, a little dizziness, and a headache. And within 2 hours, I was taken to the hospital on arrival. Anna was being admitted to the intensive care unit. She was feeling tired and having a hard time staying awake, and she became sleepy, and her breathing changed. Her objective presentation: the emergency medical service arrived immediately and started to assess Anna. Anna was alert-oriented to person, place, time, and situation. Her speech was clear, spontaneous, and logical. Her bilateral pupils were 3 regular, brisk, equal, round, and reactive to light. She had a left facial droop. Her tongue was midline. Anna had left hand, arm, leg, foot weakness. She was still able to lift it, but she had decreased sensation on that side. She had some numbness and tingling. She had normal movement sensation of her right hand, arm, leg, and foot. A National Institute of Health Stroke Scale, or NIH Stroke Scale, assessment was completed. Her score was an 11 due to the symptoms she exhibited. EMS took her vitals. Her temp was 98.3, her heart rate was 110, respiratory rate was 22, oxygen saturation was 98, her blood pressure was 192/106. En route to the hospital, EMS alerted the emergency department of a stroke alert. On arrival to the ED, Anna was met by the stroke alert team, which consists of a neurologist and residents. They immediately assessed Anna noting that she was having a stroke, and she was immediately taken for a non-contrast CAT scan of the brain. The neurologist read the CAT scan, and Anna was having an ischemic right M1 ischemic stroke. Anna was returned to the ER. They got a set of vitals on her. Her temp was 98.5. Her heart rate was 98. Respiratory rate was 20. And her blood pressure was 176/92. The neurologist spoke with Anna and her husband, and she met the criteria to receive alteplase. And it was administered per recommendations. Complete physical assessment was completed on her. Primarily the neurological, head, eyes, ears, and throat assessments were done. Pulmonary-wise, her lungs were clear. She was having a little slight shortness of breath. Cardiovascular, she was in normal sinus rhythm, clear S1, S2. She wasn't having any ectopy or any arrhythmias. GI, her abdomen was soft. She had good bowel sounds. GU, she had no problems. She was able to void on the bedpan. Peripheral vascular, her skin was all intact. She had good palpable pulses. No edema. Muscular skeletal, she was having left-sided weakness, some numbness, some tingling, the hand, the arm, the leg, the foot. She had good movement, good sensation on the right side, the hand, the arm, the leg, and the foot. Within 2 hours of arrival, Anna was being admitted to the intensive care unit. She was easily arousable by voice. She had some slightly lethargic, and she had some shallow, rapid breathing. Her respiratory rate was 6. On the monitor, her O2 sat was 88%. So nasal cannula O2 was applied at 2 liters. Anna was being admitted to the intensive care unit, and her results were coming back. Here's a quick picture of a CAT scan. Outlined in red is where the right M1 ischemic stroke is happening, that you can see there's an alteration in the CAT scan. Here's a little cartoon example of a right-sided CVA, and just showing that there's left-sided hemiplegia, spatial perceptual deficits, tend to minimize the problems. They don't realize that there's a problem. They'll say, what's the problem? Short attention span, visual field deficits, that she was having difficulty looking or seeing to the left, impaired judgment. They could be impulsive and have impaired time concept and decreased sensation on that left side. Her lab results were coming back. Her complete metabolic panel was normal, or her complete blood count was normal. Complete metabolic panel that assesses her electrolytes, that came back also normal. Her ProTime, INR, and partial prothromboplastin time came back normal. She had an EKG, which was normal sinus rhythm, no ectopy, no irregularities or arrhythmias, and she had cardiac biomarkers that came back normal. And it was developing to being a little short of breath. She does have the history of asthma. Here are the normal arterial blood gas results. Normal pH is 7.35 to 7.45. Her partial pressure carbon dioxide PaCO2 is 35 to 45 millimeters of mercury. Reflects the adequacy of lung ventilation. Her oxygen saturation normal is 95 to 100%. Partial pressure oxygen, the PaO2 is 80 to 100%, which is the oxygen in carbon dioxide diffusion pressure. And carbon dioxide normal range is 22 to 26. Anna's lab results came back. Her ABG results, her pH was 7.33, which is acidotic. Her PaCO2 was 52 millimeters of mercury, which is elevated. Her oxygen saturation is 88%, which is a little low. She was having some hypoxia. Her PaO2 was 86%, which is a slower normal, and her bicarb was normal. Here's also a little caricature of example of respiratory acidosis. A brief explanation of the pathophysiology of CVA and respiratory acidosis. An ischemic stroke, or CVA, is a sudden interruption of cerebral blood flow, thrombus formation in the vessel. Platelet aggregation occurs immediately, initiating the ischemic cascade. Brain tissue ceases and function is deprived of oxygen for more than 60 to 90 seconds. After approximately 3 hours, the patient will suffer irreversible injury, possibly leading to death of the brain tissue and infarction. This is why fibrinolytics such as alteplase are given only within 3 hours since the onset of a stroke. Since blood vessels in the brain are blocked, the brain becomes low in energy, and thus it resorts to using anaerobic metabolism within the region of the brain tissue affected by the ischemia. Anaerobic metabolism produces less adenosine triphosphate, or ADP, but releases a byproduct called lactate. Lactate acid is an irritant which can potentially destroy the cells since it is an acid and disrupts the normal acid base balance in the brain. As oxygen or glucose become depleted in the ischemic brain tissue, the production of high energy phosphate compounds such as adenosine triphosphate fail, leading to failure of energy dependent processes necessary for tissue cell survival. This sets off a series of interrelated events that result in cellular injury and death. Damage to the blood vessels lining the endothelium is particularly important. This causes platelet aggregation and consolidation of platelet accumulation. The Roxone A2 is released, contributing to platelet aggregation and vasoconstriction that cause an acceleration of the onset of symptoms. Blood clotting proteins generate thrombin, an enzyme that converts fibrinogen to fibrin, and the reaction can lead to formation of fibrin clot. The diversity of having a stroke and a patient-specific characteristics such as collaterals and vascular composition can play a significant part in their process of having a stroke and their rehabilitation. Brain tissue is especially vulnerable to ischemia since it has little respiratory reserve and is completely dependent upon the aerobic metabolism, unlike other organs. This is what happened to Anna, as she has had the M1 ischemic stroke and CVA. The body takes over compensatory mechanisms, and this is how they impact one another. For an example, the patient can have a stroke, a CVA, and then develop acute respiratory acidosis. Respiratory acidosis is a progressive process which is an acid-base balance disturbance due to the alveolar hypoventilation, or known as the ABCs of ABGs. Production of carbon dioxide occurs quickly, and failure of ventilation promptly increases the partial pressure of arterial carbon dioxide, or PaCO2. The normal ranges, as already stated, 35 to 45 millimeters of mercury. Alveolar hypoventilation leads to an increase of PaCO2, or hypercapnia. The increased PaCO2 in turn decreases the bicarb. The PaCO2 ratio thereby decreases the pH. Hypercapnia and respiratory acidosis ensue when impairment in ventilation, perfusion, or diffusion occur, and the removal of carbon dioxide by the respiratory system is less than the production of the carbon dioxide in the tissues. As for like Anna's instance, with a history of asthma, a lung disease that can cause abnormalities in the alveolar gas exchange due to typical results in alveolar hypoventilation. Often these diseases stimulate ventilation and hypocapnia due to the reflex receptors and hypoxia. Hypercapnia typically occurs late in the disease process with severe pulmonary disease or when other respiratory muscles fatigue. Respiratory acidosis can be acute or chronic. In Anna's instance, in acute respiratory acidosis, the PCO2 is elevated above the upper limits greater than 45, which hers was 52, and accompanying acidemia with a pH of less than 7.35, which Anna's was 7.33. The central nervous system disease and or drug-induced respiratory depression. These symptoms can trigger or mimic multiple problems such as change in mental status, headache, sleepiness, confusion, loss of consciousness, and then end resulting of coma. It can cause some shortness of breath, hypoventilation, heart arrhythmias, fluctuation in heart rate, weakness, and possible seizures. Medications prescribed for CVA and respiratory acidosis include alteplase tissue plasminogen activate, which is at pharmacological classification is an enzyme. The explanation of the pathology of an ischemic stroke and respiratory acidosis and what the effects of the medication are on the body. A CVA is caused by platelet aggregation. TPA and aspirin at the cellular level break down the thrombotic or embolotic clots. This is the first line ischemic stroke medication is the alteplase or TPA. Therapeutic classification is a protein thrombolytic fibrolytic enzyme therapy. Certain criteria has to be met for the fibrolytic therapy of alteplase. Early reperfusion therapy with fibrolytics in ischemic stroke patients is the appropriate care for improving neurological outcomes. The usual dosage or administration is intravenous. Maximum dosage is base related, and the max is 90 milligrams. Administer 10% of the dose IV bolus over the first minute, and then the remaining 90% over 1 hour, following a normal saline flush to ensure that the patient receives the full dose of the alteplase. Common side effects are spontaneous bleeding, so the patient has to be carefully watched for any bleeding or any hemorrhagic conversion. Pharmacodynamics or thrombolytic action. Alteplase is an enzyme that catalyzes the conversion of tissue plasminogen to plasmin in the presence of fibrin. This fibrin specificity produces local fibrinolysis in the area of recent clot formation, which is limited to systemic protein lysis. The pharmacokinetics metabolism occurs within the liver. The dose is cleared within 10 minutes after infusion is completed. Excretion is in the urine and the feces. The plasma half-life is less than 10 minutes. Onset is immediate. Peak is 45 minutes and duration is up to 4 hours. Alteplase provides the greatest benefit in treatment for acute ischemic stroke, which is given within the first 3 to 4.5 hours initially of onset of symptoms. Drug-to-drug interactions. Alteplase interferes with antagonism of platelet function. There is age-related cautions in patients that are elderly, older than 75 years or older, can cause severe cardiovascular effects, and this is not listed on the Beers criteria list. The next medication is aspirin. Aspirin is a pharmacological classification of a salicylate. Therapeutic classification is non-narcotic analgesic, antipyretic, anti-inflammatory, antiplatelet. Usual dosage is 81 milligrams PO daily or 325 milligrams daily. Common side effects are ringing in the ears, hearing loss, nausea, vomiting, GI bleed, or bleeding in other areas of the body. Pharmacodynamics is an antiplatelet, anticoagulant action, appears to impede the clotting by blocking prostaglandin synthesis action, which prevents formation of the platelet aggregating substance thyroxone A2 and helps further prevent other CVAs or strokes. The pharmacokinetics, absorption rapidly and completely from the GI tract. Distribution is distributed widely within most of the body tissues and fluids, almost completely metabolized in the liver. Drug-to-drug interactions, it interferes with aminoglycosides, Bumex, cisplatin, erythromycin, furoscimide, and vancomycin, may potentiate ototoxic effects. There are age-related issues with aspirin, and it is listed on the Beers criteria, primarily using caution with patients that are older than 60 to 75 years old because they're more susceptible to toxic effects of the aspirin. Nicardipine. Pharmacological classification, it is a calcium channel blocker. It's used for therapeutic classification of anti-anginal or antihypertensive. The usual dosage is intravenous, 2.5 milligrams, titrating by 2.5 milligrams up to a maximum dose of 15 milligrams. Common side effects are dizziness, lightheadedness, headache, paresthesia, hypotension. Can also cause peripheral edema, palpitations, angina, and tachycardia. Pharmacodynamics. Nicardipine inhibits the flux of calcium ions into the cardiac smooth muscle. The drug appears to act specifically on the vascular muscle. It causes decrease in cardiac output and in return causes a vasodilatory effect, which its primary effectiveness is in reduction of blood pressure. Hypertension is one of the major causative factors of having a stroke or CVA. Blood pressure control is the important secondary prevention of a stroke. Pharmacokinetics, absorption completely absorbed after oral administration, and absorption is decreased when the medication is taken with food. IV absorption distribution is 90% bound to the plasma proteins. It's metabolized by the liver. Drug to drug interactions, Tagamet increases the nicardipine level, so it has to be monitored carefully and monitored the patient so that they're not hypotensive. Also, nicardipine has drug-to-drug interactions with cephalosporins, which increases the cephalosporin levels, so patients have to be monitored carefully, especially transplant patients. And there's also a fentanyl analgesic precautions that can cause hypotension, so frequently monitoring the blood pressures. Age-related issues is severe cardiovascular effects and hypotension, and this is not listed on the Bureau's criteria list. The next medication is naloxone. It's a pharmacological classification narcotic opioid antagonist that is used for patients with strokes and respiratory acidosis. Therapeutic classification is a narcotic antagonist used in CVAs or respiratory acidosis patients to reverse opiate medications and respiratory depression and change in level of consciousness. Usual dosage is injection of 0.4 milligrams per milliliter. May repeat every 2 to 3 minutes as ordered or as directed to reverse the opiate effects. Naloxone interactions, adverse reactions can cause tremors, seizures, tachycardia, hyper or hypotension, ventricular fibrillation, and cardiac arrest due to the opiate effects, nausea and vomiting, and skin issues could be diaphoresis and withdrawal symptoms. Pharmacodynamics, naloxone is essentially a pure antagonist because the duration of the action of naloxone in most cases is shorter than that of the opiate. Opiate effects may return as those of naloxone as the naloxone dissipates. The precise mechanism of action is unknown of how naloxone works, but it's thought that it involves competitive antagonism of more than one opiate receptors in the central nervous system, where the opiates bind with the receptors. Here, releases the attachment with the receptors and alleviates the opiate effects. For pharmacokinetics, absorption, the duration of action is longer after IM administration and it's more rapidly absorbed intravenously, but it can be given either way. Distribution, rapid distribution into the body tissues and the fluids. Metabolism, rapidly metabolized in the liver, excreted in the urine. Drug-to-drug interactions of naloxone is cardiotoxic drugs, may cause severe cardiovascular effects. So it has to be age-related considerations is used cautiously in patients greater than 60 to 75 years old. They have to have age-related also lower doses are usually indicated for geriatric patients because they are more sensitive to the therapeutic and adverse effects of the medication. And this is not listed in the Bureau's criteria listings. Oxygen is a classification, is a gas. Oxygen aids in the achieving normal oxygen levels and in reversing hypoxia. Induced tissue damage and malfunction. Usual doses can be administered by different means, by nasal cannula, high flow oxygen, mask, bag mask, or assistive devices like BiPAP, CPAP, or to the extreme of a patient not being able to maintain their airway mechanical ventilation. And this is oxygen's maintaining the respiratory system function. Oxygen therapy supplements acts to restore normal cellular activity. Assess for potentiating factors associated with a CVA, stroke, or respiratory acidosis. The gold standard way to assess oxygen levels is arterial blood gas, is measuring to assess if you are getting adequate oxygenation, if it's too high or too low. There's no age-related factors utilized immediately at birth until the last breath is taken. For a patient, this is not listed on the Bureau's criteria list. Albuterol, the pharmacological classification is an adrenergic. Therapeutic classification is a bronchodilator. Usual dosage is 2.5 milligrams in nebulizer. Could be administered 3 times a day or 4 times a day or as needed for patients that use their nebulizer. It also could be taken by an inhaler. It's used in CVA patients and respiratory acidosis patients for bronchodilatations to help ease respiration. Adverse effects and reactions, central nervous system could be tremors, nervousness, dizziness, Insomnia, headaches, and cardiovascular can cause tachycardia, palpitations, and hypertension. Ear, eyes, nose, and throat can cause drying and irritation. And GI can cause GI upset, heartburn, nausea, vomiting. Can also cause musculoskeletal muscle cramps. Respiratory bronchospasms can cause coughing, wheezing. The pharmacodynamics albuterol selectively stimulates the beta-adrenergic receptors of the lungs and the smooth muscles. Bronchodilation results from relaxation of the bronchial smooth muscle, which relieves bronchospasms and reduces airway resistance. The pharmacokinetics absorption after oral inhalation appears to be absorbed generally over several hours from the respiratory tract. And if it's taken, the dose is mostly swallowed and absorbed through the GI tract. Distribution does not cross the blood-brain barrier. Metabolism is metabolized in the liver. Excretion rapidly excreted in urine and feces. Interaction with drug-to-drug relations with albuterol is ephedrine. Other oral inhaled symptomatic amines and increased symptomatic effects and risks of toxicity. So avoid uses together with some certain medications like MAO inhibitors, tricyclic antidepressants can cause severe cardiovascular effects. Has to be followed closely. Avoid mixing medications together and use in caution with patients that are elderly patients 60 to 75 years or older. Age-related concerns are lower doses may be required for geriatric patients. They're more sensitive to the effects of the symptomatic amines, and albuterol is not listed on the Beers criteria list. Review of overarching concepts of nursing practice impacted by CVA and respiratory acidosis impacting key problems. According to Giddens, our book for the course, the interrelated concepts of a CVA are the alterations in impairment in cognition, mobility, hormonal regulation, gas exchange, and perfusion. Also associated with respiratory acidosis. The concepts affected by the CVA and stroke happen that interrupt the blood flow to the area in the brain, causes tissue hypoperfusion, tissue hypoxemia, and brain cell death. Cognition is the process involving the understanding of knowledge and thought. Cognition or mental status is dependent upon the optimal functioning of the brain, where with a stroke occurs that there's alteration in proper functioning. So it could assessing a patient's cognition can be challenging for nurses or practitioners because it could be interrelated with multiple reasons. So it's hard to pinpoint exactly what could be going on with the patient, because a patient could be having metabolic or physiological changes and factors that can cause what the patient is experiencing, why they're confused or have change in mental status. One example could also be respiratory acidosis is a progressive process which can be a failure in ventilation, perfusion, or diffusion. The next step is mobility. The brain controls movement, sensation, perception, coordination, and balance. Mobility is dependent upon the optimal functioning of the brain and can also be impacted by respiratory issues. When a patient is having a CVA or stroke, there's alteration in the brain function depending upon the area that's involved and where the impairment is. Alteration in mobility can be impaired proper body function, which can lead to inability to move an arm, a leg, or both an arm and leg. In return, improper body functioning can cause incoordination and imbalance, immobility, and unsteadiness. There is a relationship of patients that have impairments with physical and respiratory abilities that can also have a decline in their cognitive function. That's how these are interrelated. Hormonal regulation. The next step can be affected by metabolic or physiological changes happening with the patient, can include regulation of glucose, adequate nutrition, appropriate gas exchange, and sufficient perfusion. There can be multiple underlying causes that can trigger that may be associated with a number of variables, such as acute risk factors or new developments of dehydration, electrolyte imbalances, hypoxia, acute infection or fever, can be depriving of sleep, effects from a trauma, or side effects from medication that can cause these imbalances. The brain cannot store glucose or oxygen, so a constant supply is needed to maintain proper functioning. And with a stroke or with respiratory acidosis, that's how this can affect the hormonal regulation. The next step is gas exchange and perfusion. They're very, very closely related. CVA main origination is an impairment in gas exchange and perfusion. An alteration in gas exchange and perfusion is the primary cause of a stroke and respiratory acidosis. Basic body gas exchange is oxygen and carbon dioxide, as it was explained. And alteration in ventilation, perfusion, or diffusion. The body utilizes internal compensatory mechanisms to try to maintain homeostasis. Carbon dioxide is a byproduct of metabolism. The body will spontaneously hypo or hyperventilate, causing vasoconstriction when the body is retaining carbon dioxide, which is a potent vasodilator. Respiratory acidosis is secondary to a primary illness, so it can be associated with having a stroke and then develop further problems with respiratory acidosis, and it's a progressive process that can cause these alterations. Identifying the psychosocial concerns related to the case study. The impact of stroke and respiratory acidosis can cause anxiety and depression and alteration in body images. The impact of stroke and respiratory acidosis can cause changes in personality, mood, and emotional changes. There's a strong link between stroke, depression, anxiety, and alteration in body images. Anxiety and depression post-stroke depression is the most common stroke-related emotional disorder and affecting 1/3 of all stroke survivors. And this can happen up to a time frame of 5 years after having a stroke. After a stroke survivor often experiences emotional and behavioral changes. The reason is simple because the stroke impacts the brain, and the brain controls our behavior and emotions. If you or a loved one is experiencing feelings of irritability, forgetfulness, carelessness, or confusion, feelings of frustration, anger, anxiety, or depression are common. Women are at higher risk than men for experiencing depression. Stroke survivors struggle with psychological and psychosocial adjustments, especially having alterations in their body image that they may not be able to use one side of the body, or they may have visual deficits or speaking. They may be aphasic that they can't get their words out. Some consequences of post-stroke anxiety and depression: prolonged hospital stays, affect their rehabilitation. Patients with respiratory acidosis and CVAs have poor recovery periods, alterations in their activity of daily living. They have increased morbidity and mortality, especially in patients that have increased presence of executive dysfunctions. Patients have a poor quality of life, even with neurological symptoms, and disabilities are held constant, and many require mental health treatments. That could be either medication or seeing a therapist. Patients that have strokes and respiratory acidosis can have an alteration in their body image due to impairments that they suffer from having this stroke, which can be difficulty with their visual aspects, their speech, and moving their extremities or sensation. They could have ongoing life adjustments that the patient needs to have ongoing treatment. Anxiety, depression, grief, and sadness have a tremendous impact on stroke survivors and their families. Patients that have multiple health conditions have ongoing issues that need to be dealt with on an ongoing basis. Identifying nursing diagnosis related to CVA and respiratory acidosis according to priority. Ineffective breathing patterns less than requirements related to rapid shallow breathing. Ineffective cerebral tissue perfusion related to altered level of consciousness. Impaired physical mobility related to, as in Anna's case scenario, is left arm, leg, weak, and foot impairment. Ineffective coping related to impaired body image. Self-care deficit related to impaired physical mobility. Alteration in sensory perception related to impaired sensory sensation. And risk for falls related to left hand, arm, leg, foot impairments. Here's the list of my references that I used for my presentation. I also incorporated, and I want to thank Adam Reynolds for his input, for all his video presentations that I used to do my research, articles, our textbooks, and web references. I want to thank you for watching my video, taking the time out of your day. I hope you enjoyed and learned something new about strokes and respiratory acidosis. And if you have any questions, I'd love to answer them. Thank you very much.